everyone. Thank you so much for joining me today. My name is Rose Horowitz. I am a Pulitzer-nominated journalist and the founder of Women to Follow. I'm honored to host this episode. It's episode 20 of my Women to Follow show with my incredible guests who will meet shortly, Dr. Jamila Taylor of the Century Foundation and Dr. Josie Urbina, an abortion doctor at the Women's Option Center at Zuckerberg San Francisco General Hospital. Just want to give a few shout outs. Shout out to my producer, Stefan Kaplan, who does an amazing job. And thank you to my sponsor, Women in Technology International, which is one of the leading groups for women in technology. And you can join us, tonight. We're now on four channels. We're on Facebook, Twitter, YouTube, and LinkedIn. And just as a tiny bit of background, this is my third show looking at reproductive rights, privacy, and reproductive justice. I've interviewed, three doctors, Dr. Sophia Yan, Dr. Umbereen Nehal, and Dr. McLemore, Dr. Monica McLemore. And tonight is after. Tonight is after the Supreme Court ruled to overturn Roe versus Wade, which ended 50 years of a woman's constitutional right to an abortion. Already, we can expect about half the states will seek to outlaw or restrict the procedure, while other states, such as California and Connecticut, are looking to bolster abortion rights. So it's literally changing. It's been changing every day where we are, but that's what we expect in the long run. For tonight, I will be speaking with two trailblazers in women's health about the implications of the ruling. Dr. Jamila Taylor is Director of Healthcare Reform and a Senior Fellow at the Century Foundation. She's a well-known health policy expert who works on issues related to reproductive rights and justice, focusing on the structural barriers to access to health, racial and gender disparities in health outcomes, and the intersections between healthcare and economic justice. Welcome.
Thank you for having me.
Thank you, Dr. Taylor. I really appreciate your joining us. I know it's a really busy time for you and the foundation. And I'd like to introduce my other guest, who is Dr. Josie Urbina. She's a gynecologist with a specialty in abortion and complex contraception at the Women's Health Center at Zuckerberg San Francisco General Hospital and Trauma Center. She's about to complete her work as a fellow at the University of California, San Francisco. I think she told me in 2 days, right? And she also works as a gynecologist at the Mission Neighborhood Health Center. So welcome.
Hi, thank you. Thank you so much for having me. I appreciate it.
Thank you, Dr. Urbina. Let me start. I just, ask you some general questions about what, each of you do. So Dr. Urbina, tell us what you do at the Women's, Options Center at the Zuckerberg San Francisco Health Center.
We provide comprehensive healthcare at the Option Center at San Francisco General. That includes contraception. It includes abortions. It includes all spectrum, even special procedures. And we get referrals from both within the community as well as all throughout California and out of state.
Okay. Dr. Taylor, tell us about what you're doing.
Sure, absolutely. So I work for a national think tank, the Century Foundation. And my work focuses on healthcare reform and health equity. So looking at issues not only around reproductive rights and justice, which I know we'll talk about today, but also other issues around insurance coverage, how the healthcare system is treating marginalized communities, and really just taking a holistic view of the healthcare system, again, with making sure we're putting a health equity lens, not only on health systems, but also in terms of the public policy that has implications implications for how people get care in this country.
Okay, thank you. Dr. Urbina, can you tell us how you think since you're very close to Texas, right? In Texas, a while ago, a year or so ago, outlawed abortions past 15 weeks, I think it is. So what have you been seeing, and what do you expect to see as we go forward, subsequent to this overturn of Roe?
Yeah, so since last week, there's been just a huge response in states that were hostile to reproductive access, to actually restricting abortion and passing unrealistic and unreasonable laws like personhood laws. So in particular for Texas, when they passed SB 8, it was restricted to about 6 weeks of pregnancy, when there's sometimes fetal cardiac activity noted. So since we've been in that era of restrictions in Texas, we've been unfortunately taking care of patients coming from Texas, making their journey and showing up a little bit later in their pregnancy than I'm sure they would have liked, because they were denied their reproductive autonomy in their own states. And so we expect that we're going to see that as well with the other states that have not only trigger laws, but also that have recently passed abortion bans.
Okay. And I just saw an update on the law that there was a challenge to the 6-week ban, and so I think a judge temporarily put a hold on that, but they don't expect that to last long, but maybe for the month or so. But anyway, that's the latest on that. What are you doing? I'm sorry, Dr. Taylor?
No, I was just going to say, I mean, in the meantime, that means that, more people can access the abortions they need. So any sort of, even if we're looking at it as these incremental reprieves on, some of these restrictions, I think we want to be clear that just means, that more people can access abortion in the moment.
Yeah, well, we're glad for the reprieves, right? Dr. Urbina, what kinds of things, tell me about the patients you do see. I think you talked about that 95% of the patients tell us about that.
So about 95% are from marginalized communities such as Black, Brown, undocumented, Spanish-speaking, LGBTQ, non-binary. And that's just the way the healthcare system is set up, is that we are a safety net hospital, but we don't turn people away. And so it's a matter of the amount of barriers that they've overcome or had to overcome to be able to see us, unfortunately. And so we try to take care of as many people as possible. Sometimes when they're past the state gestational limit, we're unable to help them at our facility, but we do give referrals. And I think we're going to be seeing a lot more of that with everything that's happened within the last week.
Okay. Dr. Taylor, can you talk about what you're doing at Century Foundation? And I mean, I'm sure you were very prepared for this, but what's the focus now?
Yeah, well, I must say that I don't think that, as much as we had the leak, weeks ago and had been sort of dissecting, this potential outcome for several months, I don't think anything could really prepare us, anyone working in the women's health and rights space, for this moment. But as a think tank, the Century Foundation has really been working to lead a lot of the work around, policy analysis, coming up with policy ideas, and I know we'll get into this a little bit later in the program for, now that we're in this situation that we have seen the fall of Roe. And we know that in about half states, access to abortion, has been eliminated. The right to abortion has been eliminated. What are some of the ways that, we can see other decision makers, namely those working at the federal level, but also in the states, what can they be doing to help fill the gaps in this moment? And so policy analysis, as well as research, are really centered in the work that we're doing. We also work to influence policymakers. So while we're developing materials, to, address or think about these issues in this moment, we're also targeting a lot of our advocacy work towards decision makers to help influence what happens next at the policy level when it comes to abortion rights and access.
Can you tell us what I saw an article that the Century, you were one of the authors of 5 things that you're calling on Congress to do. And I know there must be other efforts, but can you tell us about those 5 things that you're calling on Congress to do?
Sure, absolutely. So the piece that my colleague and I, her name is Anna Bernstein, she's a healthcare policy fellow with the Century Foundation. We put together a document that basically it outlines 5 actions that the Biden administration can take in this moment. There are things that Congress can do as well, but this particular piece focused on the Biden administration. And as some of our participants may know, the Biden administration hasn't shied away from, talking about these issues as they're pressed, by the media when it comes to, what the federal government can do to help support women and pregnant people that are in need of abortion at this moment. And so we are recommending that there be a whole of government approach to protecting abortion access, which is in line with, some of the calls that President Biden has made over the last several months. One of the first things that we recommend is that the federal government declare a public health emergency. And so here, really focusing on, looking at the public health emergency that was declared during the pandemic and how that opened up opportunities for, publicly funded health insurance programs like Medicaid and others to help support people and have additional flexibility when it comes to insurance requirements in this moment. So that is something that we're recommending. We're also calling on the administration to combat disinformation around stigma of abortion care. And part of that means making sure that information is readily available for those that are trying to seek abortion services. I will say that one good thing that we saw today come out of the Office of Health and Human Services is that they have launched a reproductiverights.org website, or I think it's .gov website, that includes information for folks to go on the website, find out information on things about access to contraception, abortion care, what is allowed in terms of, the abortion service that you can access. In some places, the abortion, is no longer readily accessible in a broad situation in terms of exceptions, making sure that people know that, there are some exceptions in some places where abortion can be offered. But we also think that HHS should also be, issuing guidance to providers on, what comprehensive counseling could look like, for an example, including referrals to abortion care. Again, all of these things are able to be done even, in the backdrop of this Supreme Court decision. I think another important piece to mention too here is that we need to be ensuring that coverage of abortion is clear, in terms of our insurance sources. So not only things like Medicaid, but also private insurance. And this should be done to the fullest extent of the law. Again, due to longstanding restrictions on abortion coverage, like the Hyde Amendment that restrict Medicaid from covering abortion, it can cover abortion in the cases of rape, life, and incest. So making sure that states are clear, that coverage is available. And there are also some states that do use their own money to cover abortions under their Medicaid program, even though that's prohibited at the federal level. So those are just a few of the things that we've recommended. I think another piece of this too is that I think things are really tricky in terms of the conversation with Congress in this moment. and what can happen there. But again, we keep going back to the point that we need a federal guarantee for abortion rights in this country. And there's legislation out there that would do that. We just need the political will at the federal level for Congress to pass it and for it to get to the president's desk. But again, we haven't been successful thus far, but that is something that we continue to push as well.
And is there any change? I mean, the votes, to me, I don't know, is there any shift that we might see, or ways that you're trying to work on some of the more moderate Republicans and, any Democrats who are questioning this as a right?
Yeah, well, there hasn't been any change in the landscape of Congress since we've taken 2 votes, this session on a bill called the Women's Health Protection Act. So I think at this point we are looking at broader strategies. I mean, as you mentioned, it's not just moderate Republicans, but there are also some moderate Democrats that aren't completely on board with us when it comes to this issue. So we're having to advocate with them for this issue. But I think another key piece too in this moment, or something that I'm seeing that's different from, other times that I've worked on this issue, is that I think nationally, people are starting to make the connection on abortion rights, as well as other things like, economic justice issues, looking at the fact that when women have access to the abortions that they need, that also means that they're more productive. The college student that may need an abortion is able to continue on with her education and finish college if she has access to abortion. The mom who, may have other children, but, ended up pregnant and has decided that now is not a good time to, have another child. When she has access to that abortion, it just makes her more able to better take care of the children she already has, or, have additional opportunities within, her earning potential at work. And so this is really a broader issue that's connected to really the general well-being of women and their families. And I think we're starting to see that more. I think for me, I'm seeing in this moment than I have in the past when it comes to the conversation around abortion rights.
And is that partly because more people are fired up and are listening to many of these, economic arguments, and trying to coalesce groups to get the word out there? Like, let's say about some groups, right, are raising money to fund abortions in other states, and also, can you talk to us about the research you've done about how access to abortion, particularly, and reproductive care, particularly affects Black and Brown people and people who are poor?
Yeah, absolutely. I mean, I think part of it is, the fact that, because women do not lead single issue lives. And this is particularly true that I think Black and Brown women have been so essential in, guiding the narrative when it comes to this issue. So I think we have to give credit to, the reproductive justice movement for, helping to center these conversations in a more holistic way. I think that's a big part of why we're seeing this narrative shift, in a lot of ways. And in terms of the research, you're right. These are issues, not only issues around, access to abortion and other essential healthcare. They do have a disproportionate impact on Black and Brown women. And Dr. Urbina also mentioned this as well when it comes to her patients. And I think we also have to, sort of center this conversation also around the fact that of a maternal mortality crisis in this country. And the work that I've been able to do, as well as a lot of my other colleagues, largely those in the reproductive justice and birth justice spaces, are making the connection between, certainly, banning abortion is going to do nothing to help address our maternal mortality crisis in this country. In fact, it's going to make the issue even worse. And so really making those connections to help people understand that, the failure to support women in need of abortion, as well as, in the backdrop of, the maternal mortality crisis, will only further entrench, particularly Black and Brown women into poor health outcomes. And I think making the connection now is even more important than it has been previously. The question is, will those in power listen to us and take heed? But I do think it's important to sort of center the conversation in the fact that these are the same communities that are going to be harmed, by these, sort of twin crises in this moment. And, we can't have one without the other, right? We can't have, we can't better our maternal mortality crisis in this country or ensure that women have better access to maternity care and at the same time, restricting and banning abortion access. We just can't have those two things happening at the same time. So it is important to make those connections and realize that these are issues that are impacting the same communities.
Okay, thank you. I think the most common statistics I've seen is that, maternal mortality rates among Black women are 2 or 3 times as large, as big as in the rest of the population in the U.S.
Yes, when compared to white women, Black women are about 3 times more likely to die of pregnancy-related causes. And the disparities are mirrored as well when we think about Indigenous women as well.
Okay, thank you. Dr. Urbina, one of the things we talked a little bit about was that in the past, that the people who come to you are often a little later in their pregnancy. There's a first trimester and a second trimester. And why are we seeing that? And, in particular, how this relates to what Dr. Taylor was talking about access to the medical system.
Right. So I just wanted to say that at the facility that I work with, we take care of everybody that comes for seeking the care. So I take care of pro-choice patients, pro-life patients, or patients that are unsure of their decision if they want to be pregnant. But all 3 of these type of patients know that they want to terminate their pregnancy at that time, and so we take care of them. We also take care of patients coming from out of state, like I mentioned, that are sometimes later in their gestational age because they've had so many barriers placed in front of them. They've had to arrange for transportation, childcare, had to make arrangements with their jobs, had to find a flight, had to set up hotels. And it's a lot, like Dr. Taylor mentioned as well, it's a lot more difficult for somebody that is a minority than it would be for somebody who's Caucasian or has a higher socioeconomic status. They have more means than minorities do, and they seem to find a way around the trigger laws within their state. They know who to reach out to. They have the resources for traveling up state. But somebody who has no insurance, who is undocumented, who doesn't speak English, and is a minority in this country will have a far different experience. Will likely have trouble navigating how to get abortion care, or even to start or to look for seeking help in ending their pregnancy. And I feel like these abortion plans have never been about taking care of people. It's been always about controlling birthing people's bodies. And to give you a prime example of how this is a race and power issue, Lizelle Herrera, a Latina in Southern Texas, was charged with murder for a self-induced abortion under SB8, which, as draconian as it is, this law was intended for citizens to sue abortion providers, to sue people like me and those that aid a procedure, not to criminalize patients. And had she not been a woman or a minority, I doubt she would have been treated so harshly.
Thank you. Somebody that I interviewed when her book came out was Dr. Michelle Goodwin, is not doctor, but Michelle Goodwin, who's a constitutional scholar, and wrote a book called Policing the Womb, where she talked a lot about the criminalization of pregnancy, especially, in prison and among Black and Brown communities. And, this goes hand in hand with that idea of what we're seeing for example, in the case you cited. To understand this, there's a lot of talk in general about the increase in the use of the abortion, of the day after pill. how is that true in the communities you're serving, and why or why not is that the case?
This is the question for me.
Yes, Dr. Urbina, thank you.
Okay, so the day after pill is called Plan B, and it's not an abortifacient. It doesn't cause a pregnancy to abort. So there's some misinformation about that. It prevents pregnancy from occurring, and there's different methods. Not only do we have Plan B, but we also have another one named Ella, and we also have IUDs that have shown evidence, strong evidence to prevent a pregnancy as an emergency contraception. As far as a trend in the uptake of these particular methods, I haven't noticed anything just yet, but I know that some of these methods are more on the expensive side and aren't covered by insurance or Medicaid, which seems really inhumane that if somebody wants to seek a method to prevent pregnancy, to not have these offered across the board to anybody, regardless of their socioeconomic status or their ethnicity or their race. And I would just like to mention that historically, we try to be in partnership with patients, especially those that have been historically oppressed and have experienced reproductive coercion within the country. Like a few examples would be forced sterilization here in California, and even right now in the carceral system, and forced hysterectomies in ICE detention, and in my particular specialty, the inhumane practices that were done and experimented on Black women.
Okay. Hard issue. And why do you, tell me why you, Dr. Urbina, why did you become a gynecologist and specialize in abortion and contraception?
I knew I always wanted to be an OBGYN and then get further training in abortion care. As a daughter of Mexican immigrants, there's almost nothing more stigmatized within my culture than the topic of abortion. Yet, almost 1 in 4 of those seeking abortion identify as either Latina or Latinx or Hispanic. And then on the opposite side of the spectrum, there's not very many Latina doctors, there's not many Latina OBGYNs, and I can count on one hand the number of Latina abortion specialists that there are here in the US. And abortion is part of healthcare. In trying to normalize it within my community, it's important that those performing the abortions reflect the communities that they take care of. Representation matters. So as we saw with, our vice president being a person of color, as well as, the liberal Supreme Court justices, if representation matters. And if that's a way of me helping to destigmatize abortion within my community, I'm definitely stepping up. And studies have shown that there's improved outcomes with racial and language concordant care. I would expect the same in abortion care as well. We need more Black, Latinx, and Asian Pacific Islander abortion docs because this is a very common procedure. The complications are rare, and it's a part of the spectrum of healthcare.
Mm-hmm. And do you see this happening at all at University of California, San Francisco, with more Latina coming, wanting to go into the field?
Yes, my co-fellow, Dr. Ashley Jean-Lou, identifies as Black, and we have another incoming fellow that identifies as Latinx. But I mean, it's still very much, we still have a lot of work to do within my subspecialty. Okay,
thank you. Dr. Taylor, in the field, in think tanks that you're part of, how many people are experts like yourself across, I don't know if there's any kind of measure, but across the board, and how are you hoping to change that picture?
Yeah, well, I will say that I think generally in like the public policy sector, you definitely still don't see enough people of color navigating these spaces. I do think, though, your question about think tanks. I mean, I think, you know, unless the think tank is multi-issue, you don't see a lot of think tanks, tackling issues around reproductive rights and justice, particularly multi-issue think tanks. And so the Century Foundation is one. Before I came to this organization, I worked for the Center for American Progress, where I was leading women's health and rights work there. But again, even in these settings, I continue to oftentimes, be the only in the room. I will say one thing that's comforting is the fact that, there's so much diversity, particularly in the reproductive justice space. Women of color, particularly Black women, are leading the charge in the reproductive justice space. And so for me, it's a joy to work alongside them and lock arms with them when it comes to these issues that are, in fact, we're also living the experiences of these issues. We're moms, we're mothering in different aspects of our lives. We have had abortions. We're trying to navigate being parents and, raising children and, trying to keep our children safe. Parenting in safe environments in this moment, it is also a challenge, particularly for families of color. And so I do think that in the policy professions, it's also important to have better representation of people of color as well, because it's essential that, the policies or the solutions for some of these policy challenges are closest to the people who are impacted by them. And so that's why it's really important for us to be represented in these spaces.
Very eloquently said. Thank you.
Thank you.
Why did you, when you were 10, did you think you were going to be a health policy expert, and what, has propelled your interest in this field?
It's interesting you asked me that, because when I was 10, I thought I was going to be the first Black Supreme Court justice, the first Black female Supreme Court justice. And so obviously this year, it's been such a joy to see Ketanji Brown Jackson, become, be confirmed, and she'll be a Supreme Court justice. And so when I was 10, that's what I was focused on. But, I always wanted to work and do something political, with my career, so wanting to be a lawyer, wanted to, learn more about Congress. And, one of my first jobs, I actually cold called, my representative, Congressman Bobby Scott, who is currently serving as chair of the Education and Labor Committee in the House. And I cold called his office and said, hey, can I get a job? When I was leaving college. And, luckily they had an opening and they hired me. And that's sort of like, I think my political career in a lot of ways. And so got to work for him for a number of years, but also held a number of positions, also working in state and local government, and on campaigns and things like that. But I've always wanted to work in policy and have a part in sort of influencing how decisions are made in this country at all levels of government.
Thank you. Thank you. You still hope, you'd be our second Black justice.
Well, I will say I'm not a lawyer, and I definitely don't intend to go back to school. But but I can, especially with having gotten a PhD. But I can definitely be there, be here, and be a cheerleader for amazing women like Ketanji and others that may come to follow.
Okay, thank you. Dr. Urbina, let me turn to you and ask you, why is it, let's say that, what are some of the complications? Why did you go into the field? Because you talked to me a little on the phone before the interview about working in a Planned Parenthood clinic and how that influenced you.
Yeah, I interned during college at a Planned Parenthood, and I noticed that most of the patients were either Black or brown, and most of the providers were white and didn't identify with them. And so I feel like that kind of led to this divide of like stigmatization. Like it's okay for, within the white community for family planning to occur and abortion care to occur, but not necessarily in other communities. And so for Latinx patients in particular, I understand their background, their experiences, their challenge being part of the community, and the potential stigma that they might have to address with their families and the communities after ending a pregnancy. So I felt like if their abortion provider can connect with them on an ethnic or a cultural level, that it brings an additional level of comfort. It lets them know that what they're doing, the procedure that they elected to do, or the decision they decided to make, whether it was to end the pregnancy or continue with the pregnancy, that they're going to be okay because the person taking care of them understands them. They see them, they understand them, they understand the background and the decision-making process. And that's one of the many reasons why I decided not only to be an OBGYN, but to also pursue advanced training in abortion care and complex contraception at the University of California, San Francisco.
Well, thank you. Appreciate all your work. Tell me, why is it that you say that sometimes, people who go to Planned Parenthood clinics in your state or in other states are referred to the Women's Option Center at San Francisco General? Why is that? For the general public, we may not understand why that would be.
Mm-hmm. Mm-hmm. I want to say that access is definitely easier here in California, but it's not the same for everybody. Sometimes because of racism and health disparities, patients show up a little bit later in their pregnancy. And so some Planned Parenthoods aren't set up to take care of pregnancies later in later in gestational age. But sometimes because of social determinants of health, there's patients with comorbidities or medical conditions that would be better taken care of in a higher level of care, like a hospital or where there's resources that could take care of complications should they occur.
And what are just some examples of those kinds of complications?
Some of the complications, like postpartum or post-abortion hemorrhage, or sepsis, that are very, very rare, that happen less than 0.1% of the time. But some of the medical conditions where somebody might choose to be seen in a hospital for would be something like congestive heart failure, among others.
So a clinic like that might say, we have a patient who has, congestive heart failure, can we refer this patient?
Mm-hmm. Right. And it's not so black and white. Sometimes it would probably be better for somebody with a heart condition to undergo medication abortion than to undergo a procedure because of anesthesia. So it's not so clean cut. It depends on the gestational age and what other medical conditions they have in addition to their congestive heart failure.
Thank you. That's very helpful to understand. And with patients who come in with a fetus that, has severe birth defects, like what would those kinds of things be, and why would they be seeking? They might be seeking an abortion, whether or not they do have other children, or whether they're single or married, or what are some of those things? Because we keep hearing about, sort of the other side, the people who are against abortions are saying, you're killing a life. And yet in some religions, like in Judaism and in Muslim, religions, the most important, the priority is to save the mother's life and, over the fetus. So sort of there's a few questions there, but one is really, what are some of the common things that people would seek an abortion for? no matter what religion they might be?
Sometimes because of barriers to care, these lethal, which means not compatible with life, fetal anomalies aren't found until later in pregnancy. And even with routine prenatal care, we do an anatomy ultrasound, which means it checks all of the baby's parts, all of the baby's organs. That is usually done at 18 to 22 weeks. So that's already above the limit for some states who put, restrictions on 6 weeks, 12 weeks, 15 weeks. And some of the anomalies that are not compatible with life that people don't realize are situations in which the baby's brain is present, or when they're missing a part of the heart, or when there's multiple anomalies where it's affecting multiple organ systems, not only one, such as the neurological system, but multiple: heart, lungs, the GI system, the limbs.
And how well known is it that these defects, these major things may only show up in 18 weeks to 20 weeks versus it seems like of the 20, let's say 6 states who do have, triggers, are any of them where you can have an abortion up to 18 to 20 weeks, or are they all, up to 15 or 16? I'm not sure, I don't know what the landscape is, but so does that mean half, all the women in those states, if they find out in the 18th week that they have a major, abnormality and the fetus is not likely to survive, what options do they have right now?
Right. As far as I know, there aren't exceptions for lethal fetal anomalies. And so these patients are going to be forced to carry their pregnancies, which seems kind of inhumane. And we have yet to see what the ramifications are going to be for like prenatal testing, or prenatal screening, which, sometimes early in pregnancy you can check to see what the risk is of having something like trisomy 21 or Down syndrome. Sometimes that could totally come out normal. The screening could be normal, but yet when it comes to the anatomy scan, something else will be found that's not related to a trisomy or to a genetic anomaly that sometimes might be a spontaneous mutation or occurrence.
Okay, thank you. Very important information for us to know. I think we might have some questions from somebody is asking, is there a plan, for Dr. Taylor, is there a plan to help relocate abortion providers from states where abortions have been outlawed to states with clinics that can stay open?
I have not heard of such a plan in terms of relocating providers, but I will tell you, that there are sort of broader conversations in the advocacy community about how we can support women who and pregnant people that need to travel, to other states to get safe abortion care. And so that is certainly, a conversation that we're having across the movement. I also think that some advocates are also pushing the Biden administration to be thinking about what they can do to support travel, for these folks as well.
Thank you. Dr. Urbina, is there, okay, somebody's asking the same question. Do you know of doctors who are in this situation? And I guess they mean, who are referring other people, to states where they can be, which I think that's happening. So tell us about that and what you've seen in the last year in terms of the patients you're seeing from other states.
So what I think most people don't realize is that to be an OBGYN, there's particular milestones and competencies that you have to meet in order to become, not only to graduate from OBGYN residency to be a practicing OBGYN within all 50 states, but to also become board certified. And one of those is being competent to empty a uterus. And with the restrictions happening in these hostile states, residents who are undergoing OB/GYN training are not getting the training that they need to become full scope competent OB/GYNs. And so part of that is being able to provide abortion care. It's part of the ACGME, which regulates medical education within the US, as well as CREOG, which CREOG is particular to OB/GYN training. And these are milestones that need to be met and are stated and are in writing, and they're not being met, and residents have to try to arrange for them to get this training somewhere else. So the state of California, I think, has been welcoming to that. Some of the UC systems have been hosting residents here at University of California, San Francisco. We have been having OB/GYN residents from Texas come to get their training here, but it should be, they shouldn't have to do that. They should be able to get it at their own institution, because there's only, so many sites, and yeah, I don't think it's a equitable system.
So there's a problem, as I see it, from getting enough people. I mean, there's this high mortality rate, and at the same time, there's this problem with getting everybody, getting the people who need these certifications, that experience they need, with half of the states outlawing abortion. Is there anything that the medical community has done to facilitate these, anything that that's in the last few months that they've done to make this easier?
Our medical society, like American College of OB/GYNs and the American Medical Association, have put out statements in support of abortion, and reemphasizing that it's a part of healthcare. And however, I'm not sure how much that's done to kind of prevent legislators that don't have no medical training from passing laws that affect half the population.
Okay. Yeah, and I've seen just on Twitter, some people are saying some medical sites, not the ACOG, but other ones are not coming out as strong as some doctors would like them to see, in support of abortion rights and women's health.
Right. There's so much more that could be done. I mean, every medical society, especially within the state medical boards, could come out in retaliation of the legislation that's being passed within the respective states, and it's not being done. And I just think that my physician colleagues didn't think that it would affect them, but it does. It affects everybody. It affects every single medical specialty. It affects the people are, I hate to say it, but will die from cancer because the treatment that would have saved their life is being delayed because it'll harm the fetus, or they're not being allowed to end their pregnancy in order to enter into cancer treatment. That's just one example, but I think it will affect every single specialty, and that's where the misconception was.
It's really important. And I hope anyone who's listening, who's a doctor, is hearing that. To me, from my perspective, it seems that so much burden, there's so now, there always has been, but there's increased risk and burden on doctors, because you're now in many states the arbiters, if it is life-threatening, if having an abortion is life-threatening, or in the case you pointed to, that a pregnancy has to be terminated if a patient is terminally ill, and there's other things that take that need to happen. How does that how do you deal with that, and are you commiserating with other doctors, and how does that feel?
Yeah, it's really frustrating because I practice in California as opposed to Texas or Oklahoma or Missouri, where OB/GYNs are very much at risk of being being sued or having and being involved with the legal system. And some of the, like I said, people are going to die because OBGYNs in these particular states are so afraid of the legal ramifications that they need to stop the medical treatment. Instead of proceeding with medical treatment and what the patient needs, they have to consult their ethics and legal department first. And sometimes in the instances, the patient will be at the losing end of that. Well, the patient will bleed out from an ectopic pregnancy that happens to rupture, or incomplete miscarriage will turn into sepsis instead of being taken care of by, evacuating the uterus adequately. There will be people who will die by suicide because they'd rather end their life than continue to be pregnant. That's something that I think that people don't have no idea that, exists, but that I have taken care of patients that have attempted suicide that we were referred to our institutions. And people can't say that there's exceptions for when the patient's life in danger, because I can tell you from personal experience that my specialty, OBGYN, is the most litigious already. We have some of the highest malpractice rates for physicians, and that's without abortion bans being in play. So I can see why OBGYNs that have patients with ectopic pregnancies are transporting their patients out of state to get the care they need, because it's just such a hostile environment right now.
Yeah, can I make a follow-up to that, Rose? I mean, I'm sitting here as Dr. Urbina talks, and I'm just like nodding my head so much.
Yes, that's absolutely Dr. Taylor.
Yeah, everything that she said is also, we're seeing it mirrored in some of these restrictions that are coming down from states. Like there are states that are putting in place abortion restrictions that don't have exceptions for rape, life, and incest. And so I know that we're sort of getting into this murky space as we're talking about these restrictions in this moment. I think what we call good and bad abortions, which means that there are certain circumstances that women find themselves in that are more that we excuse more when it comes to who deserves an abortion or who deserves to terminate and not. So just wanted to lift that up, that this is, I feel like even as we have that conversation, it's almost like a moot point, because these people are going after all abortion, no matter what the circumstance is, and it's really, really frightening.
Yes, very, very. If I may ask, what was I know that I was, hoping to do a show on this before we had, the decision, the ruling. But once the ruling, hit, and the way also, the justice wrote the opinion, and the warning that, from Justice Thomas that, well, we're going to come after other things, and naming them. What was that like for you as in this field that day?
Yeah, well, he named everything except for interracial marriage, I must say, which is, he has that lived experience. So it was not certainly in his list, but there were a whole host of other things. But it's very frightening. I mean, we're talking about a right to privacy, which impacts all of us in so many different ways. And again, I think a theme for the conversation, that we've had today is that, these draconian policies, these draconian laws, they always hurt Black and brown people the most, right? They always hurt low-income people the most. They always hurt LGBTQ plus folks the most. They always hurt people with disabilities the most. And so, for those of us that center marginalized communities in the work that we do, we are frightened beyond belief about what could come next. I mean, it really feels like none of us are safe in this current moment. And so I think that also, to me, I think when it comes to the work of the social justice movement, that means that we all really need to be working together, for the common good to beat back all of these things. But it's certainly a frightening moment. It almost makes you question, what year we're in. Sitting in my kitchen table, when the decision came down, and I was just like, what year is this? Like what, I can't believe that this is 2022. And yeah, it's almost like the Twilight Zone.
It's like the middle, I don't know, it's, I learned about the Middle Ages. It's like,
Yeah.
we're back in medieval times where, a woman shouldn't have sex, shouldn't have contraception.
Right.
There's no exceptions for a woman's choice. And, even though it seems like it's a woman's issue, it's an issue for everyone. Because obviously, and many of the women, this doesn't even get talked about, aside from like cases, there are cases of rape and incest, but so many women who do have abortions, from what I've read, most of them have other children.
Yeah.
So they're not doing this on a moral level. They're doing it on what can I, how can I afford it? And, the question is for those babies born that, where there's no accommodating, it's not as though the state is saying, oh, we're going to give you, $100,000 or, $1 million or, to raise that child.
Mm-hmm.
And so many more, right now there's so many children up who are not getting adopted, and especially, older children. What happens to those, what happens to that number and those?
Yeah, you're absolutely right. And I think, the point that you're making is so important because, whereas, these are issues that sort of, demonize women. We also don't have the protections in the workplace. We also don't have to support us as parents. We don't have paid leave. We don't have pay equity. We don't have access to affordable childcare. So it really is a storm, a perfect storm, when it comes to these issues. Another thing that I also wanted to lift up to, and Rose, your remarks made me think about this, is that there are some plans that are bubbling up from the pro-life movement to help sort of address some of these things that we're talking about, these sort of like wraparound or intersectional issues that we know are challenges for moms. I was just reading a plan yesterday that Marco Rubio is introducing, and is talking about, expanding, the child tax credit in states, and, putting more funding into the WIC program, promoting marriage, having more, sort of protections when it comes to, ensuring that moms and women can get the child support that they need, which I think is it's still interesting to me in this moment, because these ideas have been floating around for so long. And now all of a sudden, these are things that, these anti-choicers, who call themselves pro-lifers are supporting in this moment, or claiming to support. Whereas, they have not come to support women and families with these things in the past. And another response to that too, is that even if, we were able to get all of those things accomplished or implemented, across the country, people will still need abortions, regardless, right? And so this is not going to, make us back down from ensuring that abortion is accessible to everyone who needs it.
Yeah. I mean, as a mother of 4 children, and I'm a white person, I know that, a child tax credit, if I were to have a 5th child, if I would have had a 5th child, would not go a long way. That these are, and there is no, unlike in Europe, there is no universal, child care. So, that's part of the problem in women, getting abortions. And one of the things I was going to ask Dr. Urbina, you said that there is a nonprofit in California that is helping. I think it's maybe called Access. Tell us a little about that and how that's helping women come to your center.
So it's one of the reproductive justice organizations called Access Reproductive Justice, and they help patients with all sorts of everything that you could think of in helping them obtain their abortion. So childcare, travel expenses, lodging expenses, food, transportation. I think that people don't realize all of the costs that come into play when you force somebody to leave their home their area and out of state.
All right. Thank you. Thank you for telling us. And I think when the show ends, you sent me a list of 4 resources for women, so we'll be able to put those out. So thank you very much. Really wise words from both of you. One of the things that I, as a founder of Woman to Follow, there is a Woman to Follow Twitter list that has almost 2,000. And I've also started, for people who are interested, a Woman to Follow abortion list that is has people like, experts, doctors, organizations, reproductive justice organizations, as a way, because one of the things that I want to hear women, speaking about this. And sometimes, you turn on the news, and as Dr. Taylor said, there might be a white male talking about this, and it's very hard to find, a more equitable and, gender and racial diversity. So that's the idea. So if you do follow Twitter, or you go to my list, you can right away see what women like yourself are saying about this without having to go through your whole feed. So that's the idea. I'll put a link to that later, or in a tweet. I think it's now like 140 strong, the list. So on that note, I will ask you, Dr. Taylor, I always ask my guests, who are your women to follow? And
Great. Great. So honored to, first of all, be a part of this conversation today, and honored to also share 3 women to follow. And these are all women that I admire, that I get to work closely with on a daily basis. The first is Anna Bernstein. She is a healthcare policy fellow at the Century Foundation, and I get to work alongside her every day. She is phenomenal, and the brains behind a lot of some of the analysis that we've been doing coming out of the Dobbs case. And so Anna is definitely a woman to follow. The next person on my list is Dr. Jamila Parrott. She is a physician, advocate, and activist. She's an OBGYN. She's an abortion provider. And she is also the president and CEO of Physicians for Reproductive Health. So definitely follow her as well. And then the last person on my list is the amazing Renee Bracey Sherman, who is, she's the executive director of an organization called We Testify. And that organization really centers abortion stories and abortion storytellers. Renee is an absolute powerhouse when it comes to the reproductive justice movement and ensuring that we center the abortion stories in these conversations. She's been so essential. She actually calls herself, or we call her, the Beyonce of abortion storytelling.
That's great. I know she's on my list. I see her, and that's terrific to know. And just so everybody knows, I do really pay attention to these women to follow that my guest name, and Dr. McLemore named Dr. Taylor as one of her 3 women to follow. So a few weeks later, here you are on my show. So, issue is not going away, right? Dr. Urbina, how about?
So there was so many to choose from, but one that I wanted to highlight that's definitely one of my colleagues here at the University of California, San Francisco, and particularly at San Francisco General, who's making an impact within their field, is Doctora Velázquez Mañana. She is finishing up her oncology fellowship, but it also has had impactful research work in equity and inclusion and addressing health disparities within oncology for Latinx. She also started a group on Twitter that is Latinx Oncology, as well as she's one of the founders of Latinas in Medicine. So she is definitely making an impact within the community for Latinas, and particularly as a role model, and increasing the pipeline to make sure that those that are underrepresented in medicine are included. And then I would just like to highlight Dr. Zakama. I had the pleasure of being her attending here at San Francisco General when she was an OB/GYN resident. She's now doing her maternal fetal medicine fellowship, which is high risk obstetrics at the University of Pennsylvania. And she started a foundation that offers scholarships to those that also identify as underrepresented in medicine. She's amazing. She's in her first year of fellowship training, but I know that she's already making an impact and will be definitely a trailblazer within maternal fetal medicine.
Thank you. Thank you so much for this. And I know that with Dr. Urbina, one of the things you sort of said was that, it's not something that most doctors necessarily want to call out because of the climate now.
Mm-hmm. Right.
Yeah. And before we go, I just want to ask any final thoughts that you want to share with people about what they, at this point, what they could be doing, what to think about, what actions they can try to, do in this climate. So, Dr. Urbina?
I would say for my colleagues in general, for my physician colleagues and those that are taking care of patients, clinicians, to talk to your medical society about being against these bills that are being attempted. It's not going to stop with abortion. It's going to include personhood, which involves frozen embryos. It's going to involve contraception as well as medical care for transgender patients. And I foresee it coming, and it already is affecting every medical specialty, but it will continue to impede on our ability to provide evidence-based medicine.
Thank you. Thank you very much, Dr. Urbina. Dr. Taylor, final thoughts.
I mean, I think my final thoughts are, and look, I've sort of had to sing this song to myself as I'm, I've been in tears, several times over the past week. And, just to tell listeners, I know it's hard, but, we gotta keep fighting. I've been so encouraged by, women across sectors speaking up on this issue, whether, they are running organizations like Dick's Sporting Goods and saying that they are going to be offering their employees funding to support travel for abortion care, or it's the reporters that are sitting in these press conferences questioning, folks in the administration or congressional members about what they're going to do, to help fill the gaps and ensure or expand access to abortion care in this moment, or advocates like myself, or the physicians like Dr. Urbina. And so just want to tell folks to, remain steadfast, stay in the fight, and we can succeed and make sure that women have access to the abortion care that they need.
Thank you. Thank you. Very eloquent. And part of, clearly I'm not anti-abortion. So part of my doing these shows is to try to educate people about what they can do and see people like you who are fighting the good fight. So thank you so much for fighting the good fight, and, continue to do it. And, we have to get out of the Middle Ages, right? We have to go to the Renaissance, I hope. So thank you. I'll just close, and I'll be with you backstage in just a minute. So thank you so much for appearing with me. Appreciate it, Dr. Taylor and Dr. Urbina. Well, it was a packed show, and I think it's just it's such an enormous question of what's going to happen, and how not only women but all of the whole country will deal with this. This overthrow of a constitutional right for 50 years. So I want to thank everyone for being here today. It's an honor to host this show, and I'll be back in a few weeks with 2 weeks with another Women to Follow show. So thank you, everyone. See you soon.